Today, we have with us Dr. Sammo Samrat Samazdar, DN Clinical Pharmacology of School of Tropical Medicine. As esteemed speaker, will talk on pharmacotherapy of allergic rhinitis with current trends.
Thank you. So, my screen is visible?
Yes, sir.
Okay, so a very good evening. First of all, I thank Team Glenmark for giving me this opportunity to sit in this e-platform with two eminent ENT specialists, Dr. Shubir Haldar and Dr. Soumya Ghatak. So today I am going to discuss on specifically the therapeutics portion of allergic rhinitis. And initially, we always should respect this gentleman, Dr. John Bostock, because in the era of evidence-based medicine, the literatures are important. And this is the first literature on allergic rhinitis that had been published. And he had described first how allergic rhinitis happen, what is the course of or allergic rhinitis, specifically how seasonal allergic rhinitis are bothersome and how to tackle that. So this was the first journal where we got the reports on allergic rhinitis. And he had mentioned, I am just putting his lines, about the beginning or middle of June in every year, a sensation of heat and fullness is experienced in the eyes, and to this succeeds irritation of nose producing sneezing. To the sneezing are added a further sensation of tightness of chest and a difficulty of breathing. So beautifully he had described the natural history of allergic rhinitis. And we always should start, and my previous speaker beautifully described all the signs, but these are the important areas that we should look upon while seeing or while suspecting our allergic rhinitis patient. And apart from that, there is obvious we need a detailed examination of eye, nose, and also skin and chest. Our stethoscope has a great importance, specifically to understand the coexisting asthma, because it has been found that 15% of our allergic rhinitis patients, specifically the children, have coexisting asthma. So while talking about therapeutics or drugs, it is very important to classify the disease. And the rule of 4 is very important here while classifying the allergic rhinitis. Basically, it is two types. One is mild variety and another is moderate to severe variety. And why the number is 4 important? Because if there is less than 4 days per week or less than 4 weeks per episode, symptoms are persistent, then we can call it as intermittent symptoms. And if it is more than equal to 4 days or more than equal to 4 weeks per episode, then it is persistent symptoms. Apart from that, we need to classify as per the severity of the disease. And for that, we need to ask 4 questions again: whether the sleep is okay or normal. If it is normal, then it is mild. If it is abnormal or disturbed sleep, then it becomes moderate to severe. Normal work or school, the quality of life is normal, then it is mild. If it is problematic, then it is moderate to severe. If there is normal daily activity, then again it is mild. And if there is any impairment of daily activity and sports, then that is moderate to severe. So any symptoms which disturbs the quality of life, then it becomes moderate to severe. So after that, we need to decide what treatment we should offer to our patient. Basically, the principles of treating allergic rhinitis patient, and we need to give some relief from symptoms. So symptomatic management is very important for allergic rhinitis, but for previous 5 to 10 years, the researchers suggest that it is not only the symptomatic relief is important, we also need to modify the natural history of disease. Otherwise, the allergy will affect the other organs as well, and it in long run it can create different types of complications. So what are the therapeutic options we have to achieve relief from symptoms? Number one, the avoidance of allergen. We need to identify what are the allergens that is responsible, and already we had discussed about skin prick test method, a beautiful method to identify the allergen triggers. So we need to avoid those allergen. Next, oral antihistamines. From long days we are using these oral antihistamines. There is intranasal corticosteroids. We are going to discuss about that. Leukotriene receptor antagonist and allergen immunotherapy. So when we are talking about the modifying the natural history of disease, then I think the role of intranasal corticosteroid, the importance of intranasal corticosteroid is increasing. So we need to modify the natural history of disease, and for that intranasal corticosteroids are very important option. And what are the other therapies that may be useful in some selective patients? That can be decongestants. Sometimes oral corticosteroids are also important. So in nutshell, if we can go by this chart, these are the symptoms. As initially we had mentioned, the primary goal of treating allergic rhinitis patient is to give them symptomatic benefit. So these are the symptoms like rhinorrhea, sneezing, nasal itching, nasal obstruction, some ocular symptoms. So what are the drugs that have more effect on this type of symptoms? So here we can see from this chart, the intranasal corticosteroids, they have a very profound action on all these symptoms. Oral antihistamines, they have also a very good response in terms of this symptoms reduction. But if we can combine intranasal corticosteroid plus intranasal antihistamine, that markedly increase the response in terms of symptomatic benefit. So here you can see how the benefit, the plus signs. And another important thing is that as we are talking about symptoms and relief from symptoms, it is always important to achieve it very quickly. And for that, the therapeutics which has a quick onset of action, they help us more. So in this regard, the intranasal corticosteroid plus intranasal antihistamine, they have a quicker onset of action between 10 to 60 minutes. So this is important, whereas oral antihistamine, they have 1 to 3 hours onset of action. So they take time. So this is why again we should revisit our practice and what practice we are generally doing nowadays, that may need some change. And why this is important, again, this is one study that has been published, that breakthrough symptoms, they are very common with allergic rhinitis patients, well-controlled allergic rhinitis patients who are going or visiting their doctors. They have a good amount of experience with breakthrough symptoms. So studies in Europe suggest that 32.8% of patients, they report moderate to severe nasal and ocular symptoms on therapy. And in US study, they had suggest that 44% of patients report suffering from nasal and ocular symptoms who are on treatment. And among them, 23.7%, so almost 25% of them have moderate to severe category of symptoms. So there also you can see why we need some good therapeutics which can cover these breakthrough symptoms. So in this particular slides here we can see among the mild variety there is also a chance of a high amount of breakthrough symptoms, whereas moderate and severe there is some chance. So 96.2% treated among this person, there is around higher rate of breakthrough symptoms, whereas multiple treatment they are getting, then also they have chance of breakthrough symptoms. And for that, what is important, that is adherence. Regarding adherence, we all know that adherence means that is a agreed thing between physicians or prescribers and the patient. That patient should follow the advices given by the physician. That advice can be lifestyle modification and also taking the medicines regularly. And adherence and compliance in allergic rhinitis treatment, it is found that it is very poor. So there is a perceived knowledge exceeds actual knowledge. Why? 29% of the patients not know the class of allergy medications they were taking. So I had an experience in my allergy asthma treatment center clinic that as we are giving a prescription to those patients, many of those patients, they don't know which drug need to take during that breakthrough symptoms. And as sometimes we need to give steroids also for short duration, and you know that prednisolone is very cheaper molecule. So we found at around 10 to 15 patients who developed Cushing syndrome like features due to taking these oral corticosteroids. They don't know about that. They only understand this is one medicine that I can take that was prescribed sometimes by ago by my physician, so I can take that, and that is giving my benefit. So they don't know what is the class of that particular allergy medicine. So it is very important to give emphasis on informed prescribing. While prescribing drug, it is important to educate our patient that this drug is for this. Otherwise, this will create this type of disaster. Changing treatment. So 26% of patients are constantly trying different medications to find one that works. So as this is a highly symptomatic disease, the patients are very much distressed. They are trying to change their own medication. So in this regard also, the informed prescribing is important, and it is important to choose the most efficient drug and most safe drug so that the patient should not have any confusion. So 42% of patients are confused by all the different allergic rhinitis medications. So someone will take a montelukast levocetrizine combination while they have some symptoms. Someone takes some fexofenadine tablet. Someone will take some corticosteroid. Someone will take some nasal spray. So this confusion is present among the patient. So this is also a responsibility from physician's perspective to address this issue. And non-compliance, 64% of patients fail to take their allergic rhinitis medication consistently. And as needed use is associated with more breakthrough symptoms. So we need to continue something which has a role in preventing or reducing the pace of natural history of allergic rhinitis. So a single medication with a more rapid onset of action, that can be advantageous, and that can be some fixed dose combination also. Now coming to what Arya says, so this is one guideline generally across the world. All the physicians, all the ENT specialists are following, because this is one of the most evidence-based guideline. So this is for untreated patient, first of all. That is the first time the patient is coming to a physician with allergic rhinitis. So we need to calculate the visual analog scale score, and as per the visual analog scale score, we have to decide what treatment should we provide. So again, the visual analog scale and the visual analog score, that is totally a symptomatic score. So if there is less symptom, VAS score is less than 5/10, then we can start with one first line medication. So what are the first line medication we have? It can be one oral antihistamines, or some intranasal antihistamines, or intranasal corticosteroids, or leukotriene receptor antagonist, or intranasal corticosteroids plus Azelastine fixed dose combination. So any first line medication we can choose. But if the VAS score is more, that is more than 5, then patient is highly symptomatic, then we have to decide, if it is intermittent rhinitis, then we can choose anything again from that first line medication. But if it is persistent rhinitis, then our treatment should contain one intranasal corticosteroid, and they are mentioning to combine intranasal corticosteroid with Azelastine, and we have to again reassess the VAS daily up to 3 days. Then if again after 3 days the VAS score is less, then we can continue the treatment if the patient is symptomatic. If it is not symptomatic, we can consider about step down therapy or stopping the treatment. But again, that it is not actually good just to stop treatment after 3 days like that. We need to gradually step down as per the symptoms. And if it is more than 5/10, then we need to step up therapy. We have to add something to that first line medication. And there is always, they are now giving emphasis to start or initiate allergen immunotherapy, and for that referral to allergologist. So allergen immunotherapy is one thing which can modify the disease, which has something beyond the symptom control. So this can control the disease pathology also. So we'll come in later slides what are the role of allergen immunotherapy. Now if the patient already taking treatment for allergic rhinitis, then this is the flow chart as per ARIA, that if there is VAS less than 5/10, if it is intermittent rhinitis, we can step down. If it is persistent rhinitis, then we can maintain the treatment or sometimes step up the treatment. But if the VAS score is more than 5, again they are giving emphasis on using intranasal corticosteroid or intranasal corticosteroid plus Azelastine. So the take-home message from this particular guideline is intranasal corticosteroid and Azelastine combination has a profound role while treating allergic rhinitis patient. These are few recommendations from ARIA, that is oral or intranasal antihistamines are less effective in controlling all rhinitis symptoms than intranasal corticosteroids, as already we had seen in our previous slides. However, they are effective in many patients with mild to moderate disease, and many prefer oral medication. So this is one common outlook of our patient. They will not take inhaler, they will not take nasal spray, they want to take some oral medicine, and they are also happy if you prescribe them some prednisolone tablets also. But it is again important from our side to give some time to the patient, to educate the patient, so that patient can understand the importance of intranasal corticosteroids. So the comparison between oral and intranasal antihistamine differ in their result. So there is no final conclusions have been drawn as per ARIA. In patients with severe rhinitis, intranasal corticosteroids are the first choice in treatment. Onset of action takes place after a few days. So this is one disadvantage of using only intranasal corticosteroids. So the concomitant use of an oral antihistamines and an intranasal corticosteroids does not provide better efficacy than intranasal corticosteroids alone. So what is the take-home message from here? That if we can, if we just think we will give one intranasal corticosteroid and along with we will prescribe some antihistamine, that will not give something extra to the patient. Rather, if we can combine one intranasal corticosteroids and intranasal antihistamines like Azelastine, they are more effective than either intranasal corticosteroids or antihistamines monotherapy. And this fixed dose combination is indicated for patients in whom intranasal corticosteroid monotherapy is considered inadequate, with severe allergic rhinitis, or patients who want a quick relief of symptoms. Who already we had seen, if we can just combine these two drugs, intranasal corticosteroids and intranasal antihistamine, there is a marked reduction from all symptoms of allergic rhinitis within 30 minutes to 4 hours. So this quickest onset of action. So this is why this combination is giving emphasized, and they had mentioned about Azelastine and Fluticasone Propionate nasal spray in their guideline, and there are some studies like pollen exposure chamber study. These also confirm the finding. Now coming up to some meta-analysis of total nasal symptom score and with this intranasal corticosteroids plus intranasal antihistamines, what are the results? So this meta-analysis suggests that if we can combine intranasal corticosteroid and intranasal antihistamine, they have better efficacy over intranasal corticosteroids and intranasal antihistamine monotherapy. So it is always better to combine these two instead of giving one. And what happened? What are the results of oral antihistamines versus this? So intranasal antihistamine plus intranasal corticosteroid is superior to oral antihistamine plus intranasal corticosteroids in improving nasal symptoms for allergic rhinitis patient. Even if we just consider the different side effect of oral antihistamine, that will be also not present if we just give one nasal spray which contain intranasal corticosteroid and intranasal antihistamine. So there is one study that has been published in this journal. We can see here if intranasal corticosteroid and intranasal antihistamine combined, there is better outcome. So this is one real world evidence study done in different parts by ENT surgeon. So here you can see how there is improvement happened before consultation and after consultation. So 65% moderate to severe allergic rhinitis patients require step-up therapy, and many patients using non-intranasal corticosteroids plus intranasal antihistamine medications were uncontrolled. When they are switched to fixed combination of intranasal corticosteroid and intranasal antihistamines during the consultation, there is benefit. So again, this study suggests that if we can combine these two, then that will create increased nasal efficacy, increased ocular efficacy, quicker onset of a nasal response and ocular response. So if we just combine these two, intranasal corticosteroid and intranasal antihistamine, this give us more efficacy and more quicker response as the primary, and these are the primary reason why we should combine these two. And that is why ARIA recommend, you can see from the first line to last line, they always prefer INCS plus INH, that is intranasal corticosteroids and intranasal antihistamine. So what about Indian guideline? Again, the combination of these two, the recommendation is like that in patients with seasonal allergic rhinitis, either a combination of intranasal corticosteroids with intranasal antihistamines or an intranasal corticosteroids alone is recommended. And the choice of treatment will mostly depend on patient's preference, local availability, and cost of the treatment. And they recommend generally during the initiation of the treatment, as there is a quicker onset of action, a combination of intranasal corticosteroids with an intranasal antihistamines, because they act faster than only using intranasal corticosteroids. And so it might be preferred by some patients because it will give a quicker symptomatic relief. And for seasonal allergic rhinitis, combination of intranasal corticosteroids with an intranasal antihistamines rather than intranasal antihistamines alone is recommended. So it is always, there is no role of only using intranasal antihistamines. Now coming to one molecule, one steroids, intranasal corticosteroids, that is Mometasone Furoate. This can be a new generation intranasal corticosteroids. So what are the advantage of this particular molecule? We all know that glucocorticoid receptor is one of the very important receptor which present inside the cytoplasm. And you can see here the relative binding affinity is much more in favor of mometasone compared to the other one. So here I want to say that here the fluticasone means fluticasone propionate. Fluticasone furoate has almost similar type of glucocorticoid receptor binding capacity like mometasone. So mometasone has another benefit, that is it has lower systemic bioavailability. For other drugs, while we are talking about some antibiotic, we always, and giving it orally, we always see which drug has much more bioavailability, because we want that this drug should reach the plasma in a good amount. But here we are talking about intranasal corticosteroids. So the drugs which reaches more in blood, that can lead to more toxicity. So here we want more drug should present locally, less drug should available in the plasma. So here is the condition where less bioavailability means better drug in terms of safety. So here you also can see the mometasone has a very low systemic bioavailability, but they have very faster onset of action compared to other intranasal corticosteroids. Again, the Fluticasone Furoate has almost equal onset of action and almost equal bioavailability like Mometasone. And whether it is safe, because we understand its efficacy, its effectiveness. Now, is it safe? So long-term safety to see epithelial changes. So there was study done for 1 year, long time. So there is no significant change in that epithelial thickness that taken after 1 year of treatment with this Mometasone nasal spray. And there is no significant change in response to Mometasone Furoate nasal spray treatment in the ratio of epithelial cross-sectional area to length of basement membrane. So morphologic examination of nasal biopsy specimen showed a decrease in focal metaplasia, no change in epithelial thickness, no sign of atrophy after the treatment with Mometasone Furoate. So we can conclude like that it is safe drug. And what are the sensory attributes of Mometasone Furoate and Fluticasone Propionate nasal sprays? Because patient experience is very important. As we are talking about a disease which requires symptomatic benefit, so patient reported outcome is very important. So based on this study, it has been seen that the different sensory attributes like scent, odor, immediate taste, aftertaste, less drip down throat, less run out nose, soothingness, irritating property, urgency to sneeze after taking nasal spray. In all these sensory attributes, Mometasone Furoate nasal spray is preferred compared to Fluticasone Propionate nasal spray for allergic rhinitis patient. And now coming to the another molecule that is used for intranasal antihistamines, that is Azelastine. This is again 10 times more potent than chlorpheniramine at the H1 receptor site. And apart from that antihistamine property, they have something extra, like they have anti-inflammatory actions related to downregulation of intracellular adhesion molecule 1 expression. So in allergic rhinitis, there is overexpression of this ICAM1. So they help to downregulate those things. Also, they prevent activation of inflammatory cell, different migration and inhibition of the synthesis and release of different types of chemical mediators like leukotrienes, superoxide anions, free oxygen radicals, kinins, inflammatory cytokines. So this is why this antihistamine is approved for the treatment of seasonal allergic rhinitis and non-allergic vasomotor rhinitis also. So this is the study that has been shown that Azelastine nasal spray was significantly better than cetirizine tablets in reducing the symptoms of seasonal allergic rhinitis. Now coming to another part, apart from the nasal spray, we all understand the need of antihistamine. Sometimes we need to prescribe antihistamine, and regarding antihistamine, which is important, this not the middleman. We all know this middleman, that Ronaldo, who is a striker, prolific striker, who always scores multiple goals. But this two other person is also very important, and we need to focus them also. They are world famous defender. They are not defenders. They are also, or not only they are a good defender, they also have an ability to score goals. So they protect their own goals and they take that ball from the opponent and go to the opponent goal and can score goal or help their team to score goal. So antihistamines are like that. They are not only antagonist, they are not H1 antagonist, they are inverse agonist. So they block the histamine and they have a property to opposite action like things to antihistamines. Like if we use some antihistamines like cetirizine, they reduce the allergic inflammation, itching, sneezing, rhinorrhea, not only by blocking the H1 receptor, but also by producing one action just opposed to histamine action. And that is why the H1 antihistamines, which are first generation, which have a property to have a blocking property, or that is the inverse agonism to other receptors like serotonin, alpha adrenergic or cholinergic receptor, they have profound side effect. So that is why we need some antihistamines like second generation antihistamines, which are more specific to the H1 receptor. And for that, there are lots of questions come into our minds that how long we can use antihistamine. So there were no evidence of any negative effect with long-term administration, long-term regular administration of antihistamines. And even if there are some studies which suggest that some patients, after taking 20 years of antihistamines, they not getting any serious adverse effect. But if we go by the regulation or a good amount of clinical trial data, the longest clinical trial had been done with levocetirizine for at least 1.5 years, and that suggests there is no adverse event even if we use 1.5 year levocetirizine. With Azelastine, there is some studies of around 6 months to 12 months. Fexofenadine also 6 months to 12 months. So there are studies that suggest that they are not produce that much of side effect. And both for rhinitis and urticaria, this hypothesis is confirmed. And there is one concept that if we can use antihistamine for prolonged duration, whether it can produce tachyphylaxis or not, it not produce any type of tachyphylaxis. But while using antihistamine, even if we are using second generation antihistamine, we need to consider these side effects, these adverse effects, because as they are inverse agonist, if we use antihistamines like cetirizine or levocetirizine or fexofenadine, there is a chance of reduction in the central nervous system neurotransmission, production of sedation, even if with these newer second generation antihistamines like fexofenadine and Azelastine like things, and they can produce a reduction in the cognitive function, and there may be some neuropsychomotor performance disability, and increased appetite leads to weight gain. Muscarinic receptor, alpha adrenergic receptor, IKR channel, serotonergic receptor, they are not that much involved by the second generation antihistamines, but they are definitely involved with first generation antihistamines. So we have to be very cautious regarding their use. And here I just want to focus one thing, that is neuropsychomotor performance disturbance with H1 receptor inverse agonist like antihistamines, and what our common prescription generally nowadays for allergic patients is combining montelukast with any antihistamine. And if we go by recent black box warning on montelukast, they increase the tendency or suicidal tendency in persons, and in US FDA they had made this black box warning. So now you will not find the place of montelukast in the step 3 also in the GINA guideline. So montelukast use more than 15 days or 1 year or 1 month, more than 1 month should be prohibited. Otherwise it can cause different types of neuropsychiatric illness. And there are some other considerations. While patient may have some kidney issue, so which drug is safe while kidney is compromised, then it is fexofenadine is safe. Azelastine dose need not to modify. But if a patient is on levocetrizine, we need to adjust that dose. These are the thing. And if the patient is taking desloratadine, we need to be cautious if patient's renal function is impaired. Now, when there is some cardiological issue, then Avastine, Nizolastin, better to avoid, because they are little bit pro-arrhythmic. So better to choose fexofenadine, levocetrizine, or bilastine if there is high risk of cardiovascular disease. So when there is hepatic impairment, then we can use bilastine, desloratadine, fexofenadine, levocetrizine, like that. But Avastine better not to use, and Nizolastin should not be used. In pregnancy, cetrizine, levocetrizine, loratadine, they are safe drug. We can use this group of antihistamine in pregnancy. In elderly population, strongly we should not use any first generation antihistamines, because it will produce anticholinergic side effects. So this drug should be avoided, and always it is better to choose second generation antihistamines. Now coming to this slide, and I'm sorry, there is. Yeah. So while we are talking about allergen immunotherapy, it is very important tool nowadays for treating our allergic rhinitis patient. So first of all, we need to diagnose properly whether the patient is suffering from allergic rhinitis or some non-allergic causes. So if it is confirmed that the patient has allergic rhinitis, then allergen immunotherapy is a very important tool to treat those patients, and they have effect on all these mechanisms. I am telling in nutshell. We all know that in allergy, what happened? T helper type 2 mediated reactions are much more. So we need something which can block this Th2 type of reactions and increase the Th type 1 type of reaction, so that the balance can come back again. And for that, if we use allergen immunotherapy, they have a intense role on stimulating that particular Treg cell, T regulatory cells. That T regulatory cell will inhibit that Th2 type of cells, and as they are inhibiting the Th2 type of cells, there will be the Th1 type of reactions will be more, and there will be formation of more IgG, and that IgG will block the IgE mediated reaction. So by this mechanism, allergen immunotherapy works. But detection of a patient, that this patient is suffering from allergic rhinitis, that is very important step to get success in allergen immunotherapy. So this is the taken from one slides from a biologics in role of biologics in asthma, one of my presentation. I just want to highlight here also that as asthma has different types of phenotypes. Allergic rhinitis also have different types of phenotypes, and if these phenotypes are same, so there is high chance that getting success from those biologics that was used in asthma. And already there are studies that role of omalizumab, which is a anti-IgE and monoclonal antibody, and that has a blocking role on the IgE to bind with that Fc epsilon receptor 1. And we all know that if the IgE bind with that Fc epsilon receptor, that can cause the release of histamine. So omalizumab can block that reaction. but we need something more in terms of beforehand. If we can block this, like this, you can see the IL-5. So if we can block IL-5, then that blocking of IL-5 generally help us to counter that eosinophilia. And for that, there are monoclonal antibodies like mepolizumab is nowadays available and now used in asthma. And it has been written in their product monograph now, and there are some studies also suggest if asthma associated with chronic rhinosinusitis, then also there is a role of mepolizumab. So we can use mepolizumab in that subset of patient. And very recently, 2020 December, benralizumab is approved in India also. So which is not a which does not have a direct blocking property to that interleukin 5s, but they block the interleukin 5 receptors, and therefore they stimulates that antigen dependent cellular cytotoxicity and reduce the eosinophil level. So these also have a potential role in allergic rhinitis patients who are also suffering from asthma, severe asthma. So these drugs need to take care. And another drug is there, dupilumab, which blocks IL-4 and IL-13, but they are not tested in the background of allergic rhinitis. They are generally used in asthma, severe asthma. They have some benefit in atopic dermatitis, coexisting atopic dermatitis patient also. So in nutshell, I am coming to my summary slide. Allergic rhinitis prevalence is increasing day by day, and we need something to give our patients symptomatic benefit. Healthcare seeking behavior is important. Patient always come to us if they have some symptoms, and allergic rhinitis is one of the disease which produce bothersome symptoms. So the patient will come to us, and we need to early diagnose this case, this allergic rhinitis, and we need to offer rational therapeutics to these persons. And while considering Montelukast and other combined antihistamines, we need to be very, very careful. And here the visual analog scale has an very important role for decision making, that what type of drugs we should prescribe. And there are lots of evidences now with allergen immunotherapy, and now it is high time that we need to give more focus on this allergen immunotherapy, so that we can move from symptoms or symptomatic relief to pathophysiological benefit. So I am not going, I am sorry, I am very sorry that this line came in this particular slide. I overlooked that Bilastine is safe. Bilastine is today's not a topic for today's discussion. So thank you once again. And this is Tulsi, and long back, maybe 2000 years back, this also was recommended for allergic patients. They had, our Ayurveda had documented that this Tulsi and honey has a role in reducing inflammation and reducing allergy in reduction of asthma. Thank you for giving me this opportunity once again. I'm over to Dr. Shubir Haldar, sir.
Thank you, Dr. Samadar, sir, for your excellent and convincing talk on pharmacotherapy in allergic rhinitis. Now we can start discussion and take questions from our esteemed colleagues. Before that, may I ask one question to Dr. Shambho?
Yes, sir, please.
Actually, just now you told that we should focus more and more on allergic immunotherapy. So what is the selection criteria of patients for allergic immunotherapy, and when should we refer to that?
Yes, sir. So if we go by the ARIA guideline also, they are also now recommending the untreated patient who is coming to our clinic first time with allergic rhinitis, we can start allergen immunotherapy. Even in case of treated patients, there is always, they are recommending that allergen immunotherapy is the option. But even if the patient is untreated, because it is a progressive disorder, so if we treat early, then it is always gives a benefit. And that what I had mentioned before also, we need to explore whether not confining our therapy to symptomatic benefit only, whether we should move from symptomatic benefit to pathophysiological benefit. That is the question of our hour, and that is why ARIA is now recommending from very initial point of time when there is a proper diagnosis of allergic rhinitis. So this is very important. We need to diagnose allergic rhinitis, because if there is the rhinitis is due to some other causes, non-allergic causes, then allergen immunotherapy will not give any benefit. Ultimately, the patient will not get benefit. The name of allergen immunotherapy will be maligned. So the important criteria for allergen immunotherapy is to rightly diagnose allergic rhinitis patient.
Okay, thank you, Sambo. Dr. Somo Ghotok is here. Dr. Ghotok is here.
Yes, sir, I'm there. I'm
Okay.
here, sir.
Let us take questions from the learned audience. Okay. Can anyone
Yes,
read
sir.
the questions?
Yes, sir. Yes, sir. We have few questions, sir.
Please read out the questions.
Yes,
Please.
sir. The first question is, what is the best treatment for acute sinusitis? This question has come from Dr. Rabiul Islam, who's a consulting physician.
Dr. Ghotok, please answer.
Is it? Yes, sir. The question is about acute sinusitis.
Yes, sir. Yes, sir. Acute sinusitis, sir.
Okay, even though it is unrelated to today's topic, but the issue is that according to the EPOS guidelines, that is European Position Paper on Sinusitis, acute sinusitis in its initial 4 to 5 days is basically a viral rhinosinusitis. So instead of giving antibiotics, we are supposed to give steroids which will act, intranasal corticosteroids, which are going to act as an anti-inflammatory agent. And if there is rhinorrhea and other things, we can give oral antihistaminics. Subsequently, if the symptoms persist more than 5 days, or if there is fever or there is purulent secretion, then we might think about bacterial role in the acute sinusitis. And for ABRS, we have to add an antibiotic as well as nasal decongestants. That would be the treatment for acute sinusitis.
Thank you, sir. So the next question is again by Dr. Rabiul Islam. What are the risk factors for allergic rhinitis, sir?
Dr. Ghotok.
Risk factors for getting allergic rhinitis or risk factors related to the disease? I did not understand the question. That is
So I
what
think
would
it
like to-
means for getting allergic rhinitis. The statement is risk factors for allergic rhinitis. So from my understanding, it means the chances for getting the allergic rhinitis.
So chance of getting allergic rhinitis, as I said, is totally dependent on the genetic makeup of the person. The person is genetically predisposed to be to have an increased sensitivity to an allergen. That is the only risk factor, and that is modified by the environmental factors. As I said, this hygiene hypothesis that I elaborated on is that if that particular person in his youth is not exposed to adequate number of infectious agents, and there is no interaction with siblings and others, that gives a predisposition to allergic rhinitis and increased risk for atopy, as I would put it.
Okay, noted, sir. So we do not have any such questions. Requesting the audiences, if you all have any questions, please put it in the chat box before we conclude the session.
Dr. Bhatto,
So in the meantime, yes.
may I ask one question? Dr.
Sure,
Bhatto,
sir.
please.
Yes, sir.
How understanding of immune system helps us to diagnose and treat allergic rhinitis?
So, as I said,
I think he's muted. We cannot hear you.
Dr. Bhatto?
yeah, I have unmuted, sir. I did not notice it. As I said, I was saying that until and unless we have an understanding of the immunology of allergic rhinitis, we cannot understand the recent advances in treatment that Dr. Shambho has so beautifully elucidated for us, because we have to understand that this is primarily a Th2 pathway driven inflammation that is triggered by allergens. And once, how does the Th2 pathway act? When the antigen presenting cell is presenting the peptide to the Th2 cell, there is an outpouring of interleukin 5, which is then stimulating production of IgE antibodies by transforming the B cell to a plasma cell. So we can, as he elucidated, this plasma cell is then again producing IgE antibodies on exposure, repeat exposure to an allergen. So we can block the IgE using omalizumab. We can block the interleukin 5 by using Shambho, it is
Mepolizumab. Mepolizumab
and the newer one, that benralizumab, isn't it?
Yeah. Benralizumab actually a blocking agent for that IL-5 receptor. It is not directly blocking IL-5. Yeah.
So if we do not understand what is driving the inflammation, how can we control that inflammation? That is the issue. What we have been doing so far is just we are treating the symptoms. That is, if the patient is having rhinorrhea, sneezing due to histamine, we are blocking it. If the patient is having profound inflammation, the continued inflammation, we are using the intranasal or systemic glucocorticoids. And the third thing about immunotherapy is the importance of immunotherapy. That has to be stressed. If you do not understand the immunologic mechanism, what I stressed in the presentation is that allergic rhinitis will have a phenotypical similarity with all the non-allergic rhinitis, which will also present with sneezing rhinorrhea. So first, we have to decide that inflammation is IgE driven by doing the skin prick test and establishing a diagnosis of allergic rhinitis. And then we can thus allow the patient to have a chance at immunotherapy, which is the only one that is supposed to increase the quality of life, supposed to be a disease modifying treatment now, because all others are symptomatic management. Only immunotherapy is a disease modifying management. So all this cannot be done unless we know the entire immunological pathway. That is why I stressed on the immune system.
Yeah, I think one thing I just want to add, that in the field of allergic rhinitis, there is a great need to have some biomarker dependent treatments. So we all know that in asthma, there is profound researches had been done. They had classified asthma broadly now by Th2 Th2 mediated asthma and Th1 mediated asthma, Th2 high asthma, Th2 low asthma, and there are lots of biomarkers they are using, like FeNO, like ECP, like absolute eosinophil count. So there is also a need in the field of allergic rhinitis regarding this type of things. And we all know that, as you all already depicted beautifully, that allergen immunotherapy has the role to modify the natural history of disease. Intranasal corticosteroid has the role to modify the disease, and there is some role for future biologics which also can modify the disease pathology. So with that, I think I have to leave, if with permission from Dr. Shubir Haldar sir, if you can allow me to leave